We have a 68-year-old male with a history of BPH and CKD, baseline creatinine of 1.3, coming in with suprapubic pain for 4 days. He ran out of finasteride 5 months ago and forgot to ask for a refill. He has suprapubic tenderness to palpation, and his creatinine is now 4. Foley catheter is inserted, and he has 2 liters of urine output. The nurse pages you 4 hours later, stating that he's made another 2 liters of urine output. You tell him to start drinking as much water as possible, but the following day, his SVPs become a little soft. High 90s. What type of fluid should you give him? Normal saline, LR, half normal saline, or maybe LR. So there's only 3 choices, but you know. Try and put your nickel down. Okay, I'm going to make the argument that the answer is half normal saline. So let's go over what's going on. This is post-obstructive diuresis. So my team happens to be on, so we're seeing exactly this, but let's go over things a little systematically. Think of this like post-ATN diuresis. You may be asking, what's the pathophysiology of this? It's uncertain. That's why the explanations are really tiny here. I don't want you to focus on that. The diagnosis can be made if one of the following occurs after you drain the initial amount of urine. If your urine output is greater than 200 cc's an hour for 2 consecutive hours, or your urine output is greater than 3 liters over 24 hours. So your kidney's not working and it's trying to reestablish a gradient. So there are 2 arms of this. Monitoring is to look for vital signs, to evaluate for signs of intravascular depletion. You want to check the urine output very frequently. You want to check electrolytes every 12 hours. And maybe you want to get cardiac monitoring. But how exactly do we treat this? Our goal is to avoid excess hypovolemia. Your kidneys are attempting to recover, so you just want to support them. If you don't give them enough fluid, they can actually go into a pre-renal AKI while the kidneys are trying to figure things out. To do this, you want to give them unrestricted access to free water by mouth, and sometimes you give them IV fluids. The combination of PO plus IV should be about 75% of urine output. If you're going to give IV fluid, give it in the form of half normal saline. Let's discuss why. So your recovering kidneys like to dump out excess salt and urea. That then then water follows salt and urea. So this can lead to hypovolemia. If you give normal saline, you're just giving them salt. And if you give them too much salt that their recovering kidneys can handle, you will actually just make the diuresis worse. So you may then ask, why half normal saline? Well, you're balancing 2 things. The fluid's potential to resuscitate and your fluid's potential to contribute to diuresis. That's why half normal saline is a happy medium. LR also has too much salt in it, so that's why LR was the wrong answer there. So in summary, for post-obstructive diuresis, to diagnose, urine output greater than 200 cc's an hour for at least 2 consecutive hours, or urine output greater than 3 liters over 24 hours. For monitoring, look for vital signs of intravascular depletion, check the urine output frequently, and then check lights every 12 hours, and maybe even consider cardiac monitoring. The treatment is entirely supportive. Have them drink a lot of water, and if you need to give them IV fluids, usually half normal saline. To review what's going on, your recovering kidneys dump out excess salt and urea. Water likes to follow salt and urea. This leads to hypovolemia. So if you give recovering kidneys more salt than they can handle, you will just contribute to the patient's diuresis. So half normal saline is a nice balance of a fluid's potential to resuscitate versus the fluid's potential to contribute to diuresis. That's it. We're all done. What questions do you all have?
Is there ever any role for checking a random urine sodium in situations where the picture might be mixed?
It's a fantastic question, Dr. Kaneshiro. So in the first 24 hours, the answer is no. There are actually 2 different variants of post-obstructive diuresis. There's a pathologic and physiologic. Everyone ends up turning into a physiologic diuresis. So after 24 hours, if you get a urine sodium and it is greater than 40, it means that you are still in the pathologic phase. So you must wait at least 24 hours before this is going to turn into the physiologic phase. So that's more advanced for those of you cool kids out there.
Thank you.
No, thank you. All right, everybody. Dr. Larson is up next week, so it's not me finally. You get some variety.